Changing the scene a little bit, you've been hearing about different lesions, and we're going to go to a different topic, talking about chronic hyperoxygenation in fetal heart disease, and can this be used as a fetal intervention? You've probably heard us talk a little bit about acute hyperoxygenation as a diagnostic tool, and I'm really going to be focusing on it as a therapeutic in this talk, and what evidence do we have, which is not a whole lot, but we'll kind of go through it a little bit. And I think the big question for this audience is, can chronic administration of oxygen help the fetus with congenital heart disease? So first of all, I'm just going to take a step back a little bit and talk about some old studies. Like, why do we think this is going to help? Where did this come from? This is a really old study from the 1960s done in sheep, but if you look at this graph, along the x-axis is fetal blood oxygen level, and along the y-axis is maternal blood oxygen level. And they show that if you get pregnant sheep, the mother's oxygen, that increases the fetal oxygen content. So this tells us that oxygen does cross the barrier. You can increase oxygen level in the fetus in a pregnant mother. So then there were some studies done where they said, okay, well, what happens when we give oxygen specifically within the heart? So if you look at the left, these are the partial pressures of oxygen. So the higher those are, the more oxygen there is. And so if you look, we can start here at the IVC. We're at 34. Because the other blood comes in, this is coming from the ductus venosus, because other blood is coming from the SVC and IVC, the pulmonary artery blood level is only about 14. And you can see that because of the ductus venosus flow crossing the foramen valley that's oxygenated, here we're looking at the ascending aortic blood, and it's a little higher oxygen. So the highest level is here, but you're still getting high level oxygen in the aorta. So when they give oxygen to these fetal sheep, you can see that the overall PaO2 goes up. That did not change the oxygen delivery to the pulmonary artery, but did change the oxygen delivery to the ascending aorta. So this suggests that the oxygen level is going up, but most of that oxygenated blood is crossing the foramen valley and increasing oxygenated blood to the fetus. So this was another study done. This is really interesting. They put the fetal sheep in a hyperbaric chamber, which allows you to get really high oxygen levels. And so again, we have our baseline diagram on the left showing the same things. And what they did is, if you look at this partial pressure of oxygen, it went from 26 to 319, right, in this hyperbaric chamber. So really high oxygen levels. And we also are looking at flow in this. So 173, this is how much flow is going to the heart, to 156. This was not significant. And if you go to the, now we look to the pulmonary artery, with this much oxygen, the flow to the pulmonary artery, this is just looking at flow, not partial pressure, went way down. So where is that oxygen going? And what it is going to the ductal circulation. So it's going, out to the pulmonary artery circulation. It's going to the left side and coming back. And you can see, because it's going to the pulmonary circulation, going to the left side, the ascending aortic flow went way up. So we're basically we're lowering the pulmonary vascular resistance, diverting flow from the ductus to the pulmonary vascular bed, to the left atrium, to the left ventricle, out the aorta, okay? So, and they also looked at, well, when does this happen? When in gestation? And they looked at 90 days, 110 days. This is sheep, so they have a different gestational age. But basically saying the later in gestation you give oxygen, the more effective, the bigger change you're going to get. So just so you guys know the baseline of where all these studies came from, we say, okay, oxygen can go to the fetus, oxygen can drop pulmonary vascular resistance, oxygen can increase to the left side, and this is really best late in gestation. So what did we learn from all these early studies? We know that hyperoxygenation increases umbilical vein PaO2, which is oxygen level, increases ascending aorta PaO2. We also increase flow to the ascending aorta, and is most effective in late gestation. So then what about humans? So in the 1980s, this was thought to be a possible treatment for intrauterine growth restriction, IUGR. And this was, Lancet is a huge journal, and this was a major study done in the Lancet back in the 80s. And they took 6 fetuses, one was a twin pair with severe IUGR, and they had actually measured their cord blood and showed that they actually had low oxygen delivery. So they gave them acute hyperoxygenation. They gave the mothers oxygen via a non-rebreather. They tested mom's oxygen level. It rose. They couldn't test the fetal oxygen level. And they gave this via a non-rebreather for 24 hours a day. They did it acute, and they showed that it rose, and then they gave it chronically to see what happened. And what's interesting, so one died, the rest survived. They did increase aortic flow by Doppler in all these fetuses that survived. So great, we increased aortic flow of oxygen. Wonderful. However, they did not increase the growth, which was the whole point of the study, right? If we increase cardiac output, if we increase oxygen delivery to the brain, if we increase oxygen delivery, can we increase growth? It was ineffective. And so basically they say, well, we might have improved fetal condition and survival, but it was inadequate in increasing placental transfer of nutrients since the fetal growth velocity was unaffected. So this was sort of, there was less enthusiasm. This is another study looking at maternal hyperoxygenation for IUGR, and basically said, even though the treated patients, we saw improvement in Doppler flow and blood gas, we didn't see any difference in perinatal outcome. And basically, then in the 80s and 90s, the enthusiasm for oxygen as a treatment diminished. And that's why most of you probably aren't seeing it now. So as interest waned, it was very safe, but it wasn't very helpful. So why put mothers through this? There was another resurgence of interest in hyperoxygenation, and this is a really famous article by Rasenin and colleagues, again, looking in human fetuses and said, well, when are they most responsive to oxygen? Is it sort of like the sheep? And they looked at they did acute hyperoxygenation at 20 to 26 weeks. This is baseline with oxygen and taking off oxygen. And this is looking at the pulmonary, the pulsatility index as a measure of reactivity. And you can see there's no response to oxygen at 20 to 26 weeks. But when they looked at 31 to 36 weeks, they had this decrease in pulsatility index suggesting increased oxygen responsiveness in the third trimester. So this kind of got interesting again, and can we use it in other diseases besides IUGR? So the question is, could this now be used to treat growth of left-sided structures in congenital heart disease? And as you heard from Dr. Reichik yesterday and Dr. Pevandi today, we know we have abnormal oxygen delivery in congenital heart disease to the brain. So if you're increasing PaO2 of the ascending aorta, can we also increase neurodevelopment somehow? So remember this from yesterday. I spoke about the short, fat left ventricle versus a long, skinny left ventricle yesterday, and that we think that the long, skinny left ventricle is due to poor flow, to limited flow across the left side. So this came up, and this is again a paper that multiple of us has highlighted from Dr. Reichik's group, looking at how acute maternal hyperoxygenation improves left heart filling in fetuses that have an atrial septal aneurysm. So this is one of the first studies looking at, atrial septal aneurysm can be debated whether this is real congenital heart disease, but it is abnormal physiology. And as you saw a beautiful example yesterday from Dr. Reichik, when you have an atrial septal aneurysm, you're diminishing flow across the mitral valve, and sometimes the left side looks long and skinny and underdeveloped. They can get coarctations, usually they don't. But they showed that if they gave acute hyperoxygenation, the left side filled more, there was decreased atrial septal excursion and increased LV filling by Doppler, and increased and change in direction of aortic flow. So this is a direct observation that in heart disease, in a fetus, sort of heart disease, that you could improve left-sided filling in a child, again, with heart disease, fetus. This was a study, so this triggered interest in the sick kids laboratory. This is MRI data, and you saw Dr. Pevandi go over a lot of this. This is a single patient. They had a lot of interest and said, hey, could we do this? Can we prove this by MRI in human fetuses? We've already done this in sheep fetuses. This is a similar example. I know this is a little confusing, but we're again looking at IVC flow here. We're looking at total flow. And I think if you just pay attention to, this is the milliliters across the main pulmonary artery and milliliters across the ascending aorta. And they said, okay, if we give acute hyperoxygenation, can we increase flow across the ascending aorta? This was an underwhelming study because they did increase flow across the pulmonary artery bed. This went from 14 mLs to 34 mLs, but it all went backwards across the atrial septum. It did not cross the mitral valve or come across the ascending aorta. So despite this other study with atrial septal aneurysm say, hey, this is really helping aortic flow, this study in a true borderline left ventricle said, hey, it's not really crossing the ascending aorta. But it was one single patient who might have had diastolic dysfunction. So, however, the same group did a series of different heart conditions and said, well, what's happening with maternal hyperoxygenation and flow? So they looked at flow across the pulmonary vascular bed and across the ductus arteriosus and said, well, almost universally it is increasing across the pulmonary bed, decreasing across the ductus arteriosus, just like that last patient. But in some patients who have borderline left ventricles or HLHS, these are the ones in red or LV, they did see flow across the ascending aorta. So despite that one patient not seeing flow, there were several cases in which they saw increased flow by MRI across the ascending aorta. So, could this be a therapy? This is all acute hyperoxygenation, okay? This is giving oxygen, measuring pre-post by MRI. So the question was, with these two studies out, with the work from Sick Kids and the work from Dr. Rychek, could chronic hyperoxygenation, if you're constantly having increased flow to the left side, we say no flow, no grow, increased flow, increased grow, can that help? So this is the first study that investigated this. This is from Thomas Kohl from Germany. And now one note, this is a single center study, single author. There was no controls, but looked at 15 late gestation mothers. So again, late gestation, gave them chronic intermittent oxygen, and said, does the left side grow? And they showed that the left side structures grew. Now they didn't have a group that didn't have chronic oxygenation. This was it was a very heterogeneous group of patients. But it was perhaps some evidence that this could help grow left-sided structures. So then we decided to take this on as a clinical trial at our hospital. And this was published, you guys can see, back in 2015 in Ultrasound and Obstetrics and Gynecology. But we basically took mothers that had a long, skinny left ventricle, and we had to be in the severe category. They had retrograde flow across the aorta. And we did not include HLHS. Fetuses who we thought we could not grow the left side were not included, or severe valvar aortic stenosis. They couldn't have any extra cardiac anomalies either. So we basically first made sure that they responded to oxygen. We gave them acute hyperoxygenation to make sure that flow increased across the ascending aorta, and any responders were offered enrollment in the study. And I will say everyone responded except for one mom at 25 weeks and 4 days. We brought her back a week and a half later, and she responded. So everybody responded. And we enrolled 9 mothers, and we used 9 historical controls that were basically the consecutive 9 mothers before we started the trial. It was like the consecutive 7 and then 2 who declined the trial. So they were overlapping a little bit in time and cared for at our institution. And we looked, the main outcome was, how did the valve annuli grow? So first of all, this is the aortic flow calculated, using VTI and aortic annular measurements after acute hyperoxygenation. And you can see that all 9 had increased flow across the ascending aorta, but to a varying amount. And on average, that was about a 28% increase. And here we go looking at the outcomes. So this first graph is the aortic annulus, and the second is the aortic annulus in a subgroup. So the first is, how did the ascending aorta grow in all patients? So the red are the hyperoxygenation, the blue are the non-hyperoxygenation. And you can see that there's a little bit of divergence. So the group overall was about 1 millimeter bigger. So we had about 1 millimeter of growth with only 9 patients. It didn't meet significance. Now, we looked at moms who were actually compliant. So of the 9 moms, only 5 were compliant with the protocol and actually wore oxygen. They had to wear oxygen about minimum of 8 hours a day. And so we had some moms that were at 2 hours a day. So we said, well, let's look at just the compliant ones. And if you look at the compliant ones, we did see a significant difference between the two, although a very small study, with a difference in the ascending aorta, or the aortic annulus, of a little over 1 millimeter growth by the end of gestation. When we look at the mitral annular growth, we saw, sort of a trend, but it was not really significant for the mitral annulus. But again, this was fetal life also, and as we learned yesterday, the left side doesn't always fill, so the mitral annulus sometimes takes this ovaloid shape, and we were measuring from a 4-chamber view, but did not increase on the fetal scans. Now, interestingly, we looked at fetal weight, estimated fetal weight as well, and there wasn't a difference, but it was sort of interesting that the group that got hyperoxygenation was sort of diverging a little bit lower. Again, not significant, but we put this in the paper too to say, hey, this is something we definitely need to keep our eye on. And if we look, my boxes got all messed up. When we look at postnatal characteristics, what happened afterwards, so none of the groups had a difference, if we'll look here. But if you do look overall at just the mean z-scores, the z-scores in all the left-sided structures were all a little bit bigger than the non-left-sided structures, but nothing was significant. The biggest difference was in the ascending aorta with a z-score of negative 1.2 compared to a z-score of negative 1.9. So we looked at this as sort of optimistic. Maybe we can encourage some growth. Maybe we need to improve compliance. Maybe we need to change the protocol a little bit. If we looked at outcomes, it was a little hard to compare because they were a little bit heterogeneous in what they had. In the control group, everyone had intervention. 3 had an arch repair via thoracotomy, 1 via sternotomy, which is considered like a bigger deal, more kind of a more extensive arch repair. 2 had complex arch and mitral valvuloplasty, 2 had more complex BIV, and 1 ended up as a single ventricle. So even though 1 had a single ventricle, 5 had kind of complex repairs. And in the other group, 3 had a thoracotomy, same as the control group, 4 had a simple arch repair via sternotomy, and 2 were single ventricle. So not too much difference, although you might say they were maybe less complicated. But it was just a pilot study. Now, interesting, this is a paper out of China that came out shortly after our paper, and they used a very, very similar protocol, except we really did the most severe group, borderline left ventricles that we thought were at risk of going to HLHS, but they all were basically coarctation. And this is a group of patients fetuses they identified as likely having coarctation. They use a very similar protocol. This is mitral valve Z-scores, aortic valve Z-scores, isthmus Z-scores, ascending aortic Z-scores. What's pretty interesting, so if you look at the purple is the group on oxygen, the yellow is the group with coarct, not on oxygen, and the blue is the controls. They almost universally had growth of all the left-sided structures, and I think none of their coarct patients got surgery. So almost the exact same protocol, much more positive results than ours. It's a little hard to believe that it was so universally better than our protocol. So, I don't know how to take the data, but these data sort of were in a similar direction, but much more efficacious than ours. Of virtually no one got surgery. Also, as Dr. Pivandi said, it's really hard to predict coarct, and I think everyone predicted to have a coarct had a coarct in this study as well. So we were excited by our first paper, and we're excited to look at neurodevelopmental outcomes. That hadn't been a primary goal of our first paper, but we did have biparietal diameters, we had head circumference, we had head circumference postnatally, and we did have some MRI data, and said, well, why don't we didn't initially plan on looking this, but this looks so optimistic, let's go ahead and keep looking. And so we looked at all these outcomes, BPD growth, head circumference growth, change in MCA Doppler, postnatal head circumference, and neurodevelopmental assessments in these nine patients, 9 controls and 9 intervention patients. And if you look at the baseline, there was no difference in sort of all these measurements that we do. Nothing was significantly different in these baseline measures. What was interesting is when we looked again, the red group is the oxygenated group and the blue group is the controls. We saw a trend towards decreased fetal head circumference and a significant difference in BPD over the course of gestation in our oxygenated patients, which definitely was concerning. Now, it's only 9 patients. It's hard to say something significant in 9 patients is meaningful or should change the course of medicine, but it definitely was concerning to us, especially because we saw that the fetal weight diminishing, and we're wondering if somehow the oxygen is decreasing flow through the placenta to increase growth of the baby overall. And this is overall head circumference, and these are both Z-scores, so these are adjusted for being small already. When we looked at the pulsatility index in the MCA and the umbilical artery, we also, again, not significant, but noticed an interesting change. So the oxygenated group increased the pulsatility index, which is sort of what we'd want to see in the brain, so sort of helping brain sparing, but it even more increased the pulsatility index in the umbilical artery Doppler, suggesting that the placental vascular resistance also went up. So it's hard to measure, again, 9 patients, these are all the repeated measures, but was it to a greater degree than in our other patients? And so again, we're just a little worried what we're doing to the placenta in this situation. When we looked postnatal, there was no significant differences, but again, my boxes are weird. If you look at 6 months head circumference Z-score and Z-score for weight, there was a difference, it's not significant, but the oxygen intervention group was smaller. And so again, we saw this both prenatally and postnatally, and it gave us some concern, and that's why we published the paper. We actually had a lot of encouragement not to publish the paper because it would ruin chronic maternal hyperoxygen as a treatment. And but we felt like, we had to publish it to say, okay, even though this isn't enough to say we shouldn't do it, we need to have a lot of caution. We need to be looking at neurodevelopment, we need to be looking at brain growth, we need to be looking at placental growth. So from that study, we said basically there's no significant difference in cerebral placental resistance, head circumference, or neurodevelopmental scores after maternal hyperoxygenation, but we did see a slower fetal BPD increase and a trend towards a smaller head circumference Z-score at 6 months, and that this really needs to be closely monitored. I will, so in for left-sided heart disease, I think this did put a significant damper on a lot of the research out there. And I will say we're still enrolling in a trial that's slightly different. We're using longer maternal oxygen via nasal cannula, but we disclose these results to all of our mothers now. And I will say, our enrollment has gone significantly down, and we sort of have tempered enthusiasm for chronic hyperoxygenation and left heart disease as well. Interesting, this is a totally different use that I just wanted to mention. I think it's a single case, but this is using chronic hyperoxygen in severe Epstein's anomaly. As you've seen some people talk about, when you have Epstein's anomaly with severe tricuspid regurgitation, you have decreased flow across the pulmonary artery, and then because the RV is so big, you can have decreased cardiac output, and these babies can get quite sick in utero, and of course after birth, and the survival is low. This was a patient in which this happened. We saw yesterday, sometimes we've been using indomethacin to close the ductus arteriosus to sort of help with flow. But this was a mother who could not take indocin because of renal problems. This is just an image from the paper. She has severe TR and had a circular shunt with severe pulmonary regurgitation. So they couldn't do NSAIDs because she had intrahepatic cholestasis of pregnancy. That's right. So they decided to try acute hyperoxygenation, again, with the same goal of reducing pulmonary vascular resistance. And so if we can get more blood to the lungs, can we get more blood to the left side and have a lower chance of surviving in utero and a better chance of surviving in utero and a better chance of surviving postnatally. And the goal was to sort of attempt to cause ductal constriction and lower PVR. And so, interestingly, this is acute hyperoxygenation. We looked at these Dopplers. They looked at these Dopplers. This is from Stanford in different vascular beds. This is pulmonary vein. This is MCA. And you can see that the Doppler pattern looks much better. We have increased flow here and acutely looked better. And the MCA, this is a better picture of the MCA. You can see this is normal. This is what the baby looked like, the fetus looked like before. And now we don't have this absent diastolic flow any longer after initiation of hyperoxygenation. Now that baby had an emergent C-section at 36 weeks due to decelerations. They did go on ECMO. They got inhaled nitric oxide. They got a surgery, including what we call a Starnes procedure, which is the sort of best life-saving procedure in these severe cases, and the patient survived. I don't know if it was because of the oxygen. They did make it to 36 weeks, but this has been published and has sort of been brought up as another possible utility of chronic fetal hyperoxygenation. So future directions, we did that pilot. We're working on a pilot randomized controlled trial, but I will say we've enrolled 8 mothers over 4 years because now there's a lot less enthusiasm. Is there ever a role for a larger randomized controlled trial? Should we be trying this in Epstein's anomaly? And there are studies going on in Germany and Toronto and China for chronic hyperoxygenation for different uses. So something really to think about. I just think we need to be very thoughtful when we look at this and on placental health as we use chronic hyperoxygenation. So in conclusion, acute maternal hyperoxygenation definitely has hemodynamic effects in the normal fetus, including mildly increased oxygenation and increased aortic flow. It's unclear if it's beneficial. Chronic oxygenation is beneficial in IUGR. No one's really doing those studies anymore. When we look at CHD, there appears to be an increase in pulmonary flow and a decrease in ductus arteriosus flow. And there might be beneficial effects, but we probably need to randomize. We need to do very rigorous studies, and we need to be really looking at placental and brain health in these fetuses if we do continue to do these. And thank you guys. I hope everyone's still awake for lunch. And happy to take questions later. Thanks.